right, everybody, we're here for a new type of program today. We have not done programs similar to this, sort of like it, but not exactly like this in ever, I should say. So this is an MS Views and News program. We're doing a program today called Learning the Similarities and Differences of Multiple Sclerosis and NMOSD, which for those that don't know is neuromyelitis optica spectrum disorder. This program today is sponsored by Alexion. Okay, Dr. Calkwood will be speaking with you about MS, NMOSD, plus the disease progression of both. He'll be speaking with you about optic issues that are associated with both, and a little bit about the treatments for MS and NMO. It's not to say that anybody has NMO. It is a rare disease, but that's something that everybody needs to discuss with their doctor, only if they're not feeling well, even with the MS medications. Meanwhile, again, we have Dr. Calkwood here. Dr. Calkwood is the medical director of the Minnesota Center of Multiple Sclerosis. Come on down. Price is right.
Thanks, Stuart. Thank you very much. I want to thank, obviously, all the sponsors, Stuart, his crew, and everyone for traipsing up here to Minnesota yet again to do yet another program for MS Views and News. Minnesota Center for MS, well, we've been doing a fair amount of these with Stuart recently. We just opened our new office in Woodbury, our office in Plymouth, and we're continuing to do great things, and we're going to continue to do great things. So this is a brand new talk. I've never actually done a talk, and as a neuro-ophthalmologist, multiple sclerosis specialist, I was kind of wondering why, I've never done this talk before. But neuromyelitis optica, I will go into that in more detail. So we're going to talk about MS, well, a bunch of acronyms, a bunch of letters. MS, NMO, NMOSD, MOGAD, MOGAD. I'm going to explain what all these things mean, at least to the best of our understanding of it. So this is a very emerging field within neuroimmunology. I would loosely say MS. In some cases, these diseases I'm going to talk about, it's hard to even say they're separate diseases. In some cases, they're syndromes. But NMO is a separate disease we can identify, and I'll go through that and go through the why of that in a minute. So this is just a brief outline of what we will be going over. I'll give you a little bit of history of sort of how we got here, and then talk about some of the differences on MRI. They're pretty subtle. Hopefully you guys will be able to see, because this is kind of a visually intensive presentation. I've got a lot of MRI images with subtle little white spots on them. And fortunately, I have this fine, powerful pointer that will do things like advance the slides when I don't mean to. That's good enough. So, so neuromyelitis optica, or neuromyelitis optica spectrum disorder. We started out lumping. I think when I talk about the history of these, you'll understand why they're sort of lumped together. But we do kind of lump NMO and NMOSD. And then the new kid on the back block I'll talk about a little bit later, GAD antibodies, or the syndrome of MOGAD, I'll go into as well. So neuromyelitis optica, when I was in my training, let's not talk about how long ago that was, we didn't have NMO. We had a subtype of MS, and I have to say probably when I was in my residency and fellowship, we were really transitioning between the terminology of Devick's disease. We already kind of knew Devick's disease probably wasn't part of MS anymore. But for many, many years, and you can see the longevity of this guy, he died in 1930. So Devick, Dr. Devick, and actually I don't think he was an MD, but he's a researcher. And he and his MBA student Galt noticed this condition that happened to people that was different than MS. We knew about MS back then. MS was described in the 1800s, mid-1800s. But then this guy described something different, something that had acute transverse myelitis and bilateral optic neuritis. So we know that MS tends to cause optic neuritis. It affects usually one optic nerve or the other. It may affect them sequentially, but usually not both at the same time. So this was people who were developing spinal cord syndromes and losing their vision
in some cases simultaneously. And then he identified some cases, and also was the first to describe the opticospinal version of MS that was present in Asia, primarily Japan. So Dr. Devick, so this was called Devick's disease for many years. Next slide. I'll go ahead and try, but when I do this, you do that. Okay. So we changed the name and called it neuromyelitis optica, the NMO, long before this paper was published. But this paper was really probably the seminal presentation where we really identified NMO really is a distinct disease. We can't call it a syndrome. We can identify people who have this condition based on the presence of this antibody. And in this little schematic right there, if you can see the marker, this is a schematic or cartoon of a membrane, and there's this little protein wound through the membrane, aquaporin 4. It is a water channel. Turns out it's not on nerve cells. It's on astrocytes. Astrocytes are cells in your brain that help support neurons, but they nurture and support those neurons. But it wasn't even something related to MS. It wasn't damaging myelin. It wasn't attacking nerves. This isn't a problem in nerve cells. It's a problem in the membrane of astrocytes. And I'll show you a schematic. This subtle finding of this fluorescence was noted in a lab. Mayo Clinic was sending their MS specimens to this particular lab, and then in the lab, that staining pattern was noticed to be very, very unique, and these antibodies were directed to this transmembrane protein that was very much involved in maintaining water balance within cells. So next slide, please. Now, I'm just going to fast forward to the full timeline of kind of what went on through all of this. So if we go back to sometime around late 90s, we really converted. We're like, all right, Devick's disease just doesn't make sense. We're naming it after some dead guy, and it doesn't. Neuromyelitis optica is at least somewhat explanatory of what's going on. It affects myelitis means spinal cord. Okay, optica obviously. So then in 2020. 2002, we saw these complement deposition and didn't quite understand, and some antibody deposition. It really wasn't until it was 2005 when it was published, but 2004 was a discovery. Aquaporin 4 antibodies could be identified. Now, our laboratory techniques were fairly rudimentary then. Autofluorescence was, at the time, was a state-of-the-art technique for trying to measure and track antibodies. But as we've come a long way now, we're able to do this in other ways. But then 2000, so the discovery of this antibody changed everything. It drew a lot of attention, and tons of research started being done. Everyone was interested in, we've identified an antibody. Now, MS is not an antibody-mediated disease. In MS, it isn't antibodies that are floating around causing trouble. It's T cells. So we call that a cellular-mediated immunity as opposed to an antibody-mediated immunity problem. So two different diseases. Devick's is not MS for sure. It's proven to be its own disease by discovery of that antibody. Then a ton of research came about. And then we ultimately developed the terminology NMOSD, standing for spectrum disorder. Turns out not everybody who has NMO tests positive for antibodies. So there were people who had the very similar syndrome that appeared to be NMO, but they were testing negative. At the time, Mayo developed the first commercial. They didn't do it commercially at first, but they developed the first widespread assay, where you could send blood in, be tested for NMO. Now it's a commercially available test. So Mayo developed that test. I was actually in Minnesota and seeing patients here, and they were testing negative. Patients who had very similar things to NMO were testing negative. And at the time, Mayo felt that the test was probably something like 90-95% sensitive for NMO. Turns out probably not. And we're actually on the cusp of another revolution of our understanding, and I'll talk more about that when we start talking about MOG in just a minute. But this was sort of the history. Oh, back up one quick. So then we came to 2023, where all of these very specific treatments, so we now have 4 FDA-approved treatments, and I'll show you more of those later. But in 2023, a treatment went through a research trial that basically resulted in patients with this potentially devastating disease through the course of the 2-year study having no attacks at all, no relapses, no nothing, 0 people on treatment. I don't think we've ever seen a treatment quite that effective in any disease state for that matter. So this is a really quite remarkable and very rapid series of scientific developments. We talk about research. We think of things that are linear. One discovery builds another discovery, builds another discovery. Research is exponential. One discovery leads to 2 discoveries, 2 leads to 4, 4 leads to 8, 8 leads to 16, and so on. So we see these exponential ramp up. It's not a straight line curve. It ramps up like that. So that's kind of what we saw here from the early beginnings in 1990s going, this isn't MS, it's a different disease. All the way to now where not only can we define the disease state by a simple blood test, it's actually not a very simple test. It's a cell-based assay. It's really hard to do. At least, there are several different blood tests for NMO. You definitely want to do the one at Mayo or any one that are called cell-based assays. It's really important that you do the test in the right place. A lot of our confusion early on was the testing wasn't sensitive. It was giving falsely positive results. But the cell-based assays are very, very sensitive. So this is an amazing development of both diagnosis all the way to now 4 FDA-approved treatments. One of those treatments is 100% effective in its clinical trial. Next slide, please. So in the midst of all this, we developed a diagnostic criteria for NMO. And for a while, we were just focused on people who were positive for antibodies. I had a little disagreement with Mayo at the time. Dr. Weinshanker and I were friends, and we still are. He's no longer at Mayo. But we had some conversations about that, specifically regarding the fact that, Brian, your test isn't 90% sensitive. I'm seeing people, I'm thinking it maybe is 70% sensitive. They actually improved the test over time. But we still had this issue where we have people who test positive, and then we had people who looked like they had NMO, only they tested negative. By the way, I'm going to show you what NMO looks like in a few minutes. So the diagnostic criteria were developed, and all that blah, blah, blah on this side over here is the stuff that I have to read, and then I'll condense it down for you. So that's the diagnostic criteria is published in an article by the American Academy of Neurology. And so aquaporin 4 is that water channel. Antibodies against it. If you test positive for that and you have one typical core event. Now the core events are basically the things that we saw, the 2 things that Dr. Devick saw, optic neuritis and myelitis, spinal cord and bilateral optic nerve. Those 2 things that Dr. Devick saw, we have to add one thing that Devick and many others didn't recognize. We probably didn't start recognizing this until some case reports in the 80s, 90s, really 2000s before we really started identifying this area postrema syndrome. So, and I'm actually going to show you on the MRI, there's one place in your brainstem where if you have a problem there, it's a center that controls things like, keeping your cookies down. Sorry, I shouldn't say that while I was having lunch. But so area postrema syndrome causes intractable nausea and vomiting. Hiccups was actually another interesting symptom that people would have. So that was yet a 3rd syndrome of NMO. Now, sometimes people would have one of these or all 3 of them, and then there's a bunch of others. If you can read in the fine print, other brainstem syndromes can occur. We can see really, really weird things like hydrocephalus, all sorts of weird things. So there is a broad spectrum, but those 3 core things are really necessary for the diagnosis, having at least one of those, and that is optic nerve, optic neuritis, myelitis, a spinal cord event, and or area postrema syndrome. Now, if you're negative for the antibodies, we have a higher bar. not only do you have to have at least one of the core elements, you have to have a relapsing nature, something else has to happen, and you should have one of the key MRI findings. All right, so MOGAD, what is it? So I'm just going to introduce that here. We'll talk a little bit more about it later. Myelin oligodendrocyte glycoprotein. Now, we've known about MOG for a long time. We've known about this protein present, but we didn't quite know what to do with it. It's like, well, there's this antibody against MOG. And this is a protein, MOG is a protein that is actually it's on the very surface of the myelin. So it is in myelin, as opposed to the antibody that NMO recognized, aquaporin 4, isn't even on a nerve cell. It's on the astrocyte that helps support and nurture the nerve cell. So this was another breakthrough paper where we identified, medical science identified, Dr. O'Connor actually, identified antibodies not only in, well, some very unusual diseases. So this list of diseases along the bottom here, ADEM, acute disseminated encephalomyelitis. I'll show you some images of that later. It looks like really bad MS. It happens to someone really fast, affects cognitive function. People get confused and disoriented and things. It can be relapsing. You can see pediatric MS. Asian versions of MS, relapsing, secondary, we don't call it secondary progressive anymore, but the term still means the same thing. Primary progressive, CIS, viral encephalitides, other controls. So we found this protein in MS and some other diseases we hadn't yet defined very well. So this is probably the state of the art of kind of our thinking on this right now. This is a group of disorders of which aquaporin 4, NMOSD, is part of it, but then we have other people, other patients who test negative but have very similar symptoms and findings. And then we have these other kind of nebulous conditions, acute disseminated encephalomyelitis, ADEM. That can actually be provoked by an infection. About half the time it happens after someone's had a viral infection. It's much more common in kids, but it happens in adults. In adults, it might tend to have a relapsing character. The MRI findings are very similar. As you see the MRIs, that's where it starts getting really tricky distinguishing these things. So this is kind of the state of the art of our thinking right now, that this MOG antibody is really important. We see it showing up in multiple other syndromes. We can measure MOG in MS. Some people with NMO have MOG. Some people with NMOSD test positive for MOG, and we are probably on the cusp of redefining NMOSD. It looks as though a lot of the seronegative NMOSD people may turn out to have MOG antibodies. If you ever test positive for NMO antibodies, aquaporin 4 antibodies, you will be positive the rest of your life. If you test positive for MOG, you may only test positive in the middle of a relapse. In between relapses, you might not test positive. So it appears as though we probably have a separate syndrome mixed into our NMOSD that we're trying to sort out. So this bubble chart here is basically just to show you that things are pretty complicated, and quite frankly, we don't know what we're doing yet. We're still figuring this out. So this is a work in progress. So we'll talk more specifics about that. So let's look now, drill down a little bit more on how is the immune attack in NMOSD different than MS. We talked about the target is different, but other things are different too. Aquaporin 4 is the target. Now, in this schematic you see here, the red part is the inside of a blood vessel. This is essentially the blood-brain barrier, and these astrocytes, which, as you see, a healthy astrocyte here with these aquaporin 4 channels, these water channels here, on the surface of the astrocyte, and then the astrocyte connects and helps support and nurture the nerve. We also see the oligodendrocytes. These cells here make the myelin for the nerve. And what we see here is there is an antibody that is directed against these proteins in the membrane. That antibody, along with, this is really important, complement. Complement, there's several ways. I won't go into a lot of detail, but if you look at the schematic along the bottom, there's a few different ways that an immune cell is targeted in the case of, or let's say their immune system targets a foreign invader. But we actually harness the immune system to treat some of these diseases. So in some cases, whether a drug is antibody, whether it does its deed through an antibody mediated or through complement, can make a difference. It would definitely make a difference in how we might try to block or treat that individual. So complement and antibodies combine to attack, and we're losing battery here, and attack this astrocyte. Some of the oligocells get damaged, but ultimately the nerve cell itself is injured. You see here GFAP and neurofilament light being released that will eventually make its way into the bloodstream. These are other biomarkers of the disease. And then there are these several ways along the bottom. We'll come back to that. Complement means the antibody combines with complement in a couple other processes, which kills the cell. Antibodies can then antibodies can then attach the cell and call in another immune cell, macrophage, dendritic cells. There's a few different cells that will serve in that role, and they'll come in and kill that cell. And then there's an antibody cellular mediated where essentially the cell is destroyed in a slightly different way, but mediated through antibodies. So these two are antibody, and this one is complement. And complement is very much involved, as well as there's some antibody mediated, but that's important when we talk about treatments later on. So let's drill down a little bit on some of these key MRI differences between NMO and MS. Go back. So they can be pretty subtle, and they're not well defined. A lot of what we see in NMO really overlaps with MS. MOGAD overlaps with MS. There are some subtle differences, but you can start to get a sense of why maybe some people might be misdiagnosed, or why it would be really hard to diagnose or distinguish MS or other diseases, MS from these other diseases. Didn't at that time. Now, I didn't put the reference on there, and I forgot where I got that from. Anyway, so this is a schematic of the of essentially how NMO is different than MS. So the typical lesions that we see in NMO are going to be a little different. I'm going to show you some examples, but in the optic nerve, in fact, there are quite a bit differences. But it tends to be more in this area in the brainstem, where an MS is going to affect the brainstem more up there. We can see things around the third ventricle right here. That's gray matter. MS doesn't affect gray matter, at least not directly. It doesn't directly attack gray matter. Indirectly, it might affect it. Now, periventricular, we see that very commonly in MS. And then we may see these other areas, area postrema, periductal aqueduct. Corpus callosum is common in MS, but the hypothalamus is not. Where the lesions form within the spinal cord are even a little bit different. MS lesions tend to occur on the outside of the spinal cord. NMO lesions will extend all the way to the center part of the spinal cord. MOGAD actually will affect the gray matter in the spinal cord, so you actually see a little H sign. I'll show you an example of some of these things. All right. So the hallmark, and this is one of the things that was noticed very early on when we developed MRI imaging, pathologic specimens, when people with this Devic's disease were autopsied, we would find these significant, huge lesions in the spinal cord. Now, it doesn't project very well, unfortunately, but there is a long white strip on this one going from about there all the way down to here. And on this one, you can see a little patchy, and then I can't really see it on this, but it goes all the way down to the conus, the very termination of the spinal cord. So this patient had lesions up and down their entire spinal cord. Now, the other thing about these longitudinally extensive transverse myelitis, so these lesions are very destructive. They're big. They cause significant deficits, weakness, bladder problems, sensory, some degree of balance, and even to the point, often when someone has an attack in their spinal cord like this, they're not walking. And in many cases, some cases, they never walk again. This can be a one and done disease. One event, and you never walk again. I have several patients like that. So it's a particularly challenging disease. And you can understand, not only do we want to diagnose it, now that we have treatments to prevent it, a one and done event, we really want to identify this disease and get people on treatment as soon as possible. Highly effective treatments, ideally. And unlike MS, where a spinal cord event may have pretty good recovery, often we see very poor recovery after events of NMO in the spinal cord. Now, here's an example on this schema, those are actually MRI lesions, MRI images there. Area postrema, you can maybe see the little arrow right there. There's a place in the back of the brainstem. It's the back part of the brainstem. MS, I don't think I've ever seen MS affect that part of the brainstem. If it did, it's only because a lesion extended a little bit further. It wasn't a primary lesion there. There is a lesion in that brainstem in the area postrema. So if you saw something like that, that would be very, very unusual for MS, very common in NMOSD. In the B image there, you see a couple of lesions in the spinal cord. Now, these are the short T2 lesions. I can't see these very well myself, but there's a couple of arrows there, that one there, and that one there. And those look almost identical to lesions due to MS. The enhancement pattern with the contrast dye may look a little different. And I don't know if you can see here, but the lesion, that's the slice through the spinal cord this way. So these are images of the spinal cord with somebody sliced right down the middle. And then these are images with the slice through the spinal cord. So in the spinal cord itself, the lesion goes all the way to the center of the spinal cord. So those are unusual, as well as in the contrast enhancing, the D and the E panels here, you can see there's a little bit of a ring enhancement, and we see a little bit of that in the cross-section of the spinal cord too. So those are, ring enhancement in the spinal cord is unusual to see in MS. The MS lesion tends to enhance kind of densely and uniformly. I'll show you a few examples of those as we go forward. Not today. There we go. All right. What about in the optic nerve? So I tried to give you a sense of what a normal optic nerve looks like. And then after an optic nerve has been damaged, that nerve over time, over many months, will slowly change color. It develops pallor or paleness to the nerve. It gets kind of waxy white. So here we see sort of a pinkish optic nerve, and then here it's just sort of white. So this is a octopus visual field, a peripheral visual assessment done on a patient who had NMO, and this is what their optic nerves look like well after the fact. So that should all be white. This is a central 30 degrees of that person's vision, and they have just a little bit of preserved vision in the center island here and a little bit right there. But this is profound vision loss. We could call this blindness. This is essentially legal blindness. This person probably has a visual acuity of maybe 2,200, 2,400 and very, very terrible peripheral vision. So Devick's disease, NMO, NMOSD, when it hits the optic nerves, can be devastating, at least for vision. Now, many people with MS will lose a lot of vision when they have optic neuritis. Usually optic neuritis is only going to happen in one eye at a time. Devick's, MOGAD, both can hit both optic nerves at the same time. Can hit the optic chiasm, where your two optic nerves cross on the way to the brain. It's called the optic chiasm. Very, very rare to see MS affect that part of the brain or that part of the visual system. Very common for NMO and for MOGAD both to do that. But this can be the outcome of this disease. A single attack of optic neuritis or chiasmal neuritis can do this to a person. One and done. MS picks at you a little, robs a little more, picks at you a little more. You have attacks, you recover pretty well, and you accumulate disability in a slightly different way. But this can be a one and done event. Speaking of disability accumulation, how does it differ between these conditions? We'll say a disease, we can say NMO is antibody positive NMO is a disease unto itself. NMOSD, I think we still have to call it a syndrome. MOGAD, we're still calling it a syndrome. And actually MS is a syndrome. But bottom line is they change differently. So MOGAD I'll show you some more examples of this later. But MOGAD, you can have a single event, one and done, although people with MOGAD tend to recover a lot better, could recover a lot better than people with an MO. Although you can also about half the time see a relapsing form of MOGAD. So it can look like MS, right? Relapse, 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 and even see maybe a slight increasing baseline of disability. That's the EDSS, or disability on the scale, and time on the scale down below. So what about Aquaphor 4 NMOSD? You have relapses, but boy, there is not very much recovery as compared to relapsing forms of MS, where you have relapses recover to baseline. But as the disease or time goes on, you do start to develop more disability due to incomplete recovery from the relapses. And then there's another thing we see, the so-called smoldering MS, or that gradual, slow progression, even though we may be fully controlling the disease in measurable ways, like the MRIs aren't changing, people aren't having relapses, but if we watch them carefully over time, they just slowly lose neurological function. That smoldering part of the disease. Primary progressive, and we see in this schematic here of people just start getting worse from the get-go. So there are really quite different patterns in how the disease affects people over time and how that disability develops. Worked this time. All right. Fast forward to all of that timeline I showed you for NMOSD. We now have 4 FDA-approved drugs. I think the last one was March of this year, March of this year. And we also have some what we call off-label treatments that we use. You know, when you have a patient in front of you who's struggling and having a problem, you just do whatever you can to figure out what's going to work. I actually discovered there's a type of, it's probably a MOGAD-related condition called CRINO, chronic recurrent inflammatory optic neuritis. It's not MS. People can lose a lot of vision. I struggled for that. We used to call it autoimmune optic neuropathy. I struggled with patients with that condition. Ultimately, I found that IVIG, just trying things, intravenous immune globulin actually worked. We have recently found, and some recent papers have actually shown that. So when you're dealing with a patient in front of you who's having a problem, you try to find whatever it is to help them. So along the way, we did learn that there were some non-FDA approved treatments that would help for MS. And we have to think there are also some MS treatments that may very well help just by their mechanism of action. Remember in the schematic I showed you of NMOSD attack on the astrocytes, antibodies and complement were both involved. Some of our MS treatments actually work on antibodies, so the B cell treatments. This list over here is actually the handout we give to our patients in clinic. Instead of, you guys probably remember back in the days where you'd come in and we'd talk to you about some of those MS drugs, and you'd walk out needing practically a suitcase because there were these thick brochures. I mean, they're still around, not as much, but these thick brochures, we'd give you 5, 6, 10 of them. Go home, read about these, come back. We're going to talk about all that later, and we're going to narrow it down to 1 or 2. Patients would literally haul in a little bag out of clinic with all these things in it. Well, now we have these little links, and we hand that out in clinic, and people can follow these links to get more information about the various treatments. This list is divided into efficacy groups, but mostly lower efficacy, medium, and higher efficacy. But mostly I wanted to point out treatments that have a primary effect on antibodies. So if someone with MS, or let's say someone with NMO or MOGAD even, were misdiagnosed as someone with MS and they were on one of these treatments, they might very well work because those treatments work on antibodies. Now, will they work well? Don't know. One of the off-label drugs that we use for NMO is rituximab. Rituximab is identical molecule to Ocrevus. They're just made by different tissue cultures. Kesimpta, different molecule, works in the same way as Ocrevus. Briumvi, different molecule, slightly different molecule, works in the same way. Then we have these other treatments, but mostly what these treatments share is some impact on suppressing more likely antibodies or B cells. These are directly B cell therapies. Mycophenolate, Cellcept is another name for that, azathioprine, Imuran. And then there's a handful of other drugs that we've used along the way. Those are things that we just found that worked just by empiric trial. Try anything. And then we do small studies with, 10, 15 patients. Now, 10, 15 patients for a rare disease like MOGAD or NMO, it's a lot. And some of our research studies, that's one of the challenges in studying a disease like this. It's a fairly rare disease. It's hard to find patients to treat. So let's look a little bit at that treatment timeline. So back before we really even knew it as a different disease, we were in some cases, we thought it was a different disease, but we hadn't identified an antibody. We were trying everything, azathioprine, steroids, so chemotherapy drugs. Azathioprine is it's not as big a heavy hitter like Cytoxan, cyclophosphamide. Some of those chemotherapy drugs we use in MS hit the immune system pretty hard. Azathioprine is something that we use. Rheumatologists use it as well. It's sort of a low, in high doses, it can be a chemotherapy drug, but in low doses, it tends to be an anti-inflammatory drug. We and the rheumatologists probably use that more than most. Rituximab, mitoxantrone or novantrone. We had a very brief flash in the pan where mitoxantrone, which by the way is still the only, no, not anymore. Up until about 5 years ago, it was the only FDA-approved treatment for secondary progressive multiple sclerosis. When I was running the Shapiro Center, before Dr. Shapiro retired, Dr. Shapiro, Randy had treated maybe 500 people with mitoxantrone. I treated about 50. This was all before we thought there was about a 1 in 1,000 chance of getting acute myelogenous leukemia. That has about a 60% mortality rate. Turns out it was about less than 1 in 100, not 1 in 1,000. And also turns out it was actually probably closer to 1 in 80. And it turns out that I know of at least 5 patients of Dr. Shapiro's that died from cancers as a direct result of mitoxantrone. So you may ask why we don't use that in MS or NMO anymore. It's the toxicity. Can cause leukemia, very serious leukemia. Prednisone. In 2009, we were using IVIG. Tocilizumab was an interesting experiment. Has an impact, not easily accessible like prednisone or mycophenolate or Rituxan, even as rituximab is easier to get. Then these FDA-approved therapies that have since developed, eculizumab, sartalizumab, inalizumab, and ravulizumab. So you notice how they all end in the mob. So I'll just start calling them Sartra, Inib, Razu, and Eku. We'll have to abbreviate them because I'm running out of voice already. Now, this is a brief overview. I'm not going to go into a lot of details, but just show you. And actually, I've got to thank Bruce Cree, a friend of mine at UCSF, who he did this presentation at the AAN, and he put all of this together, which was just a really nice overview. One of the slides from his deck, a nice overview of him, basically going through the clinical trials. We don't have to go into great detail because he also boiled this down for us. And I'll show you some of that in a minute. There was a cartoon a long time ago. It was a judge in a courtroom, and he was looking at a woman behind the mic saying, "Miss Lewinsky, could you please back up a little from the mic?" So Dr. Cree also put this little summary together just to kind of break it down. So eculizumab, sartalizumab, inibulizumab, tongue twisters, all, and ravulizumab. So different interesting things they do. Complement. This is a protein called interleukin-6 is the target. And then CD19 is basically the same target as a B cell target. And then Ravi is also, this is the one that was 100% effective. So, but the drugs that seem to have some of the greatest impact are actually the complement drugs. The other really interesting thing about this is the complement drugs we can probably actually use on someone to have an effect while they're in the middle of a relapse. If we treat, like MS right now, if we treat you with a B-cell therapy, your risk of relapses will go down in about 2 to 3 months after we treat you. And it'll continue to go down for a while, but it doesn't work right away. These complement drugs can be immediately effective. So typically these patients, when they're having a major attack, are often hospitalized, and we can use these treatments in that way. But essentially we have intravenous therapy, subcutaneous, intravenous. So these are delicate molecules. They're monoclonal antibodies. That's what the MAB ending stands for. They do not pass through the gut very well at all. They don't survive the stomach acid. They have to be injected or infused. And again, the clinical trials along the way. All right. So I'm just going to have to read this to you because this is really just a breakdown and it doesn't project very well. But there are a couple issues we have to think about the different drugs. There are some risks associated with them. Complement drugs. Complement is very, very important for a couple of a certain type of bacteria, encapsulated organisms, and meningococcal infections. Pneumococcal pneumonia is and meningococcal meningitis. So these are some serious. Now our biggest concern with the complement drugs are actually bacterial meningitis. So encapsulated bacteria can be almost invisible to the immune system, but complement is very, very important in identifying and attacking, eliminating those organisms. So that's one of the issues we have to worry about, that vaccinating people for meningococcus pneumonia vaccinations are available. That's another encapsulated organism too, although we didn't see too much of an issue with that. Sartolizumab, we did see serious risk of neutropenia, drops in white blood cell counts, serious infection risks. That's a subcutaneous shot under the skin every 4 weeks. Inebilizumab, 77% reduction in attacks. Pretty good. Ravulizumab, 100% reduction in risk in seropositive patients. Same thing. It's a complement drug. We have to worry about meningitis. And it's every 8-week intravenous as opposed to the other complement drug, which is every 2 weeks. So certainly a little bit more convenient and long-lasting. Those are kind of the key breakdowns. All right. So from one rare disease to an even more rare disease. So, or at least, I'm not sure actually. We may find that this is a much more prevalent disease. Remember I told you that we can test. If you ever have the antibodies against aquaporin 4, you're always going to have them. Whenever we test, they're always going to be there. So but if you have MOG antibodies, they're not always going to be there. So we might measure MOG when you're in the middle of an attack and see that it's elevated, or worse yet, you have an attack and we don't measure MOG, and then we measure it months later and you're negative. Well, all right. MOG comes and goes. So it's much harder to identify that MOG antibody because it comes and goes. It may only be present in the middle of an attack or shortly thereafter. So that becomes a bit more of a problem. Now, here is the target for MOG. So look at the schematic on the bottom. This is a nerve cell. This is myelin. So this is on the very surface of myelin, and it's on this little shoulder. These are called the nodes of Ranvier. They're very, very important for what's called saltatory conduction. This is how a nerve conducts electrical information. Doesn't really travel along the nerve like a wire. It sort of jumps from these nodes, but it really speeds up the conduction, and it is the primary basis of how a nerve works, how it conducts electrical information. So MOG is on the surface, right on the edge of these nodes. And there's an antibody targeted to that. We also know complement is involved in that one as well. We do not have the treatments for MOG worked out nearly as well. We don't have any FDA treatments, FDA-approved treatments for MOGAD at this time. We are using off-label treatments. Those off-label treatments tend to be, we're kind of at the stage with MOGAD that we were with NMO a while back before we had targeted FDA-approved immunotherapies. We're sort of throwing stuff at the wall to see what sticks, right? So IVIG actually may be very, very effective in at least some people with MOGAD. But we don't have the treatments worked out nearly as well as we have for NMOSD. So let's look at a couple of differences between NMO, or actually MS, and MOGAD in particular. We tend to see this enhancement of the sheath of the optic nerve. So when there's an optic neuritis event, as you can see in these MRIs, I have to come around here to even point out the right one. So the, can you see the little white spots? So that's the optic, that's the globe, the eyeball. That's the optic nerve going to it. And if you, those of you up close might be able to see that. I'm standing in your way. Little white, where is it? Right there and there. That's a little bit of enhancement. So there's dye leaking in right where the optic nerve attaches to the globe. But the optic nerve itself isn't lighting up with dye. It's just the sheath. That's very unusual. You don't see that in MS. If you see that on an MRI in someone you suspect has MS, as a neurologist, you may be wrong. Then in this particular patient too, you can also, if you were close, make out that that part of the optic nerve has a lesion in it, that part of the optic nerve has a lesion in it, and part of the chiasm has a lesion. Both optic nerves are swollen. If you have optic neuritis, your optic nerve doesn't usually swell up, at least not that your regular eye doctor can see. If we take measurements through your optic nerve, and we had some measurements before, we might see that it swells a little, but it doesn't swell so much you can look in the back of the eye and see it. And if it ever does that, it doesn't do it in both eyes at the same time. So very, very unusual. So if the optic chiasm is involved, where the two nerves cross, if we see small hemorrhages in and around the optic nerve, and then we'll see these really long lesions in the optic nerve, long, almost the whole length of the optic nerve right there. Very, very unusual. Let's see if it's going to do it. Nope, you're on. There we go. All right, what about the outcomes? This is MOGAD, MOGAD optic neuritis. You get swelling in the optic nerve, as you see here, and then oftentimes the vision can recover pretty well, just like optic neuritis in MS. Occasionally, you'll see, I do measurements through the nerve regularly, something called an OCT, where we measure the thickness of the nerve cells in the back of the eye, and I track that in my patients with MS. We'll see someone who gets an optic neuritis attack might lose 10, 15% of the thickness of their nerve layer. MOGAD, NMOSD, they might lose 30, 40% of the nerves with a single attack. Although the vision may recover pretty well, in some cases, a lot of axonal loss or nerve cell damage. In some cases, people may have frequent relapses, and over time, this can lead to, well, in this particular event, early event, 16% of people may have something like blindness in one eye. With multiple events over 15 years' time, you might see 6% of people be completely blind. I'm sorry, I think I got that. Yeah, no, that's right. 6% completely blind, and blind in one eye, 36%. So MS doesn't lead to blindness. It really doesn't. It'll affect your vision. It'll affect your contrast vision. It'll cause problems with eye movement and tracking and those things, but as far as how well you see, it doesn't affect it that much, not to this degree. So another very important difference between the two diseases. All right, what about MOGAD? Now we're talking about MOGAD in the spinal cord. We can also see these huge, long longitudinal lesions, and it can even look a little bit like, in some cases, they look a little bit like MS. That would be contrast enhancement that might be consistent with MS. But the gray matter in the spinal cord, that little contrast enhancement, that little H sign, very peculiar. We really only see that in MOGAD. We don't, and again, I have to say there is overlap between the imaging findings between MOGAD and NMO. So that's one very, very unique thing. If we see that finding on your MRI, it might be, thanks. Now this one, acute disseminated encephalomyelitis, ADEM. This is another MOGAD variant. White spots all over the brain, these fluffy white things near the surface of the brain, looks really peculiar. All of that can go away. 6 months, a year later, that can be gone. Now, the people, I say kids because it tends to affect kids a little more than adults. There is an adult form, and in the adult form, in kids are more likely to have one event, and adults are more likely to have recurrent events. But kids often will have cognitive deficits even if they fully recover and even if lesions go away. We might need to do some specialized cognitive testing, even give them some educational support in some cases for children. Back up one, there we go. So I put these up just to say, this is tough. It's tough distinguishing these diseases. MS, so the optic nerve lesions in MS. You can see a little bit of one right there. That's trying to show you the chiasm involved, a full thickness of the optic nerve, a little bit of optic nerve there, and the chiasm. All this is going on in one patient at one time. There's another example of chiasmal, the optic chiasm being involved. So those are kind of subtle things, and not every person with NMOSD is going to have these kinds of lesions. They may just present with something that looks much more like MS. So it gets trickier and trickier. Thanks. What about the spinal cord? Here's NMOSD in the spinal cord. Well, these lesions right there, is it MS or NMO? This one's actually MS. That's MS. That's NMO. There's a ring-enhancing lesion right there. Lesion goes all the way to the center of the cord. But if your neurologist just looked at that lesion or that lesion, it would be hard for them to tell. So these things are not easy to distinguish from MS. The chances are we've had people with misdiagnosed. What about the brain lesions? Well, here's an example of some brain lesions where this one right here is MS. That one right there looks very similar, same place in the brain, is NMO. These fluffy lesions are MS. That's bilateral chiasm. That's some inflammation there. So there are some unusual things, area postrema there in the brainstem. So there are subtle differences on the MRIs. All right. It's important to know because the treatments or the diseases are so different, and a one and done event can happen if you have NMO or even MOGAD, although MOGAD seems to have better recovery, maybe not quite as severe as NMO. And it can really be devastating. So we need to get this right. So how can you tell? How would you know? Might be hard. Your neurologist has to look at the MRIs. They can check your blood work, but that antibody for MOGAD may come and go. NMOSD, NMO antibody is going to be there forever, but not every lab has a sensitive test. We send ours to Mayo. I think actually the testing's improved quite a bit now. But there are a couple things you need to think about. So potential red flags, just based on what we talked about tonight. Severe relapses with incomplete recovery, especially if that relapse is a vision loss or a spinal cord attack. And if you have intractable hiccups, nausea, or vomiting associated with a relapse, or that is just the relapse and no other symptoms, we have to think outside of the box. You have to think outside the box. Your neurologist should be thinking about that too. What about if you develop optic neuritis in both eyes at the same time? That would be another red flag. Or if the MRI shows it's in your optic chiasm, it would be hard for you to know that, but your neurologist should be able to figure that out. If you only had one MS attack ever, maybe it was a doozy, but you only had one ever, does MS do that? Not usually. And if you've not had any slow progression creeping in, assume you've had disease for many years, often there's some slow gradual worsening, that's more MS. MOGAD, 50% of people have one major attack never anything again. What if you're not responding to your treatment and you've escalated to stronger treatments and it's not working? Well, maybe we're not treating the right disease. And then I mentioned progression. If your lesions go away, the ADEM patient I showed you with all those fluffy white things, those can completely go away over months. If all of your MS lesions go away and there aren't any others, so just a few things to think about. Those are just some of the things where somebody with MS having symptoms or might be misdiagnosed. In general, we're going to figure that out because the treatments aren't going to work unless you happen to be put on one of those B cells, in which case, B cell treatments, in which case they might be keeping a lid on it. Historically, we've seen drugs like Rituxan reduce attacks in NMO 50 to 70% in research studies. We haven't seen a 100% effective drug off-label. And even the 70+% or better effectiveness rivals or is better than what we think is our most effective drug for NMOSD, off-label drug for NMOSD right now would be Rituxan. I would probably say, I still think probably even now the majority of people in this country with NMO probably aren't being treated with one of the new drugs. They're probably still on a legacy drug, more likely Rituxan, rituximab. Say that's probably the majority of folks. All right. I'm not sure I'm going to have enough time for this one. There was an aggressive agenda. There are some new drugs to talk about. I'll mention these only in that these are our emerging therapies for multiple sclerosis. So just briefly shifting gears, these are therapies we're expecting evobrutinib, which unfortunately failed, tolobrutinib, fenebrutinib. In the next 2.5 years, we'll see data on both of those drugs. And we're just now seeing frexalimab, gotta learn how to pronounce all those, and going into phase 3 studies. And we have CAR T-cell therapy trials that are just now forming some very, very interesting things for the future treatments for MS. Just roll on through these because there's not too much. Those are the drugs in development. And do the next one. This is a clinical trial program for tolobrutinib. This is how the frexalimab works. It doesn't actually destroy the B cells. It just blocks its communication between some of the others. So we're anticipating this drug won't really impact people's immunity to the same degree that some of our B cell treatments go. Roll on through. Yeah, roll on through that. And then the CAR T-cell therapies is wave of the future. So just a few references. And
thank you.
You're welcome.
You're welcome.
Ms. Lewinsky.
There you go. Thank you. Let's give him a round of applause. All right, so does anybody in the audience have any questions about multiple sclerosis or NMO or MOG? Nobody. Nobody wants to be first? Well, before I go into the back of the room to ask that person, we do have a person online that is asking about the CAR T cell therapy, and I know you skipped that over that one, but if you could just let them know, please.
Yeah,
about the clinical trials for this. Bill, can you back up 3 slides, I think?
So I actually went on clinicaltrials.gov and I don't see anything there yet. They are enrolling. Some of the companies are talking about, but so I'm not aware of any trials that are enrolling at this point, but this is a very exciting. Is there one enrolling? I might have missed one. When I at the ACTRIMS meeting, I talked to a couple of people where a couple of companies that were developing, but they didn't have anything that
Bristol has it now.
Bristol does? Okay.
Yeah.
BMS? Okay. Yeah, that's right. I talked to them, but I didn't.
They're already enrolling.
Oh, then I'm behind the times on that one. So, yeah, I didn't think they were enrolling already, but unfortunately that's a study that's going to require, I think the academic institutions are probably going to be doing a lot of these studies because it does require having to manipulate the T cells. So you take the T cells from the individual, you train those T cells to essentially take out T cells that are already programmed to target MS. You essentially train your immune system to take care of your immune system. So, and it's a long-lasting effect and very promising. Great strides are being made in oncology with CAR T-cell. And I will point out one thing on the image there. I used an AI program to come up with some image representing CAR. CAR stands for chimeric antigen receptor, by the way, not. So, and someone else actually pointed out there's another car. The front of a car is right over there too. So AI is maybe not quite ready for prime time yet.
So I'll be over there in a minute to get your question. Just for everybody to know that I don't know if you're on our social media from MS Views and News, but we are posting things about CAR T cell therapies and how you can potentially be a candidate.
Dr. Calkwood, can you, is there a way to just watch a person or look at a person and see if you think it's MS or whether it's NMOSD or MOG? Can you just visually get a sense?
No.
Thank you.
How was that, Stuart? Brevity?
That sounds great.
Yeah.
Okay.
Yeah, no, not really. You really can't tell.
So how do you tell the difference between MOG and NMOSD?
Right now, some of those clinical features, but they overlap even more than MS does, even more so than the features overlap with MS. So primarily we do it through biomarkers, antibody levels. As I say, MOG is the challenging one because it's not always present. So we can measure NMO, and yet we still have people who apparently have NMO who don't have the antibody. Now, do those people have MOG? Might be. I think that's kind of where we're leading. And at the AAN meeting, I was talking to Dr. Pittock, who was actually, Sean Pittock was he was in the lab that discovered the NMO antibody at the time. So it's been a large part of his career. Dr. Pittock feels that we're very close to likely breaking out MOGAD, and a subset of NMO is probably going to turn out to be MOGAD, not NMO.
Gotcha.
But they're very, very similar, very hard to distinguish.
Okay, new question.
As far as the CAR T therapy goes, my brother-in-law had CAR T cell therapy done with multiple myeloma. Mm-hmm. Is this the same thing, or
Yes.
do they target a different spike on the protein or whatever?
It's the same technology with a different target. Essentially, you train a T cell, you train that individual's T cell to attack the cancer.
Thanks. Any questions, just raise your hands, all right? Otherwise, I'll carry on. Let's talk about biosimilars, okay? What can you tell us about biosimilars? Because there's a lot to be learned there as well.
Well, so we don't have any biosimilars for any treatments for NMOSD. We do have some biosimilars for MS. So a biosimilar treatment would essentially be a generic, or the equivalent of a generic. But in a biological drug, it's not going to be, a small molecule, you can literally make it identical to another small molecule. Biological drugs are a little bit harder. So getting close, I used to say horseshoes, hand grenades, and apparently biosimilars. Close is good enough. Close counts. So you get a molecule that's pretty close in the effects and the way it happens. And the FDA studies the molecules. It's maybe not to the same rigor that the original or reference product is studied, but they do have a standard to prove that treatment is both safe and effective and going to render something fairly close to the reference drug or the trade name drug, if you would.
Thank you. Speaking about the referenced, I know it lost its patent, so how will people still be able to get this?
Get what?
Tysabri.
Oh, we hadn't talked about Tysabri as
That's
as a
right.
biosimilar, but it is one of the drugs that is available as a biosimilar. We also have biosimilars for Copaxone or glatiramer, Glatopa. We have a biosimilar. Actually, we have a generic for fingolimod, for Gilenya, a generic fingolimod, and we have a generic for Tecfidera. The difference there being is generic small molecule drugs are easy to make identical. Biosimilar drugs are biological drugs. So, sorry? Yep. So so they are very, very similar in that way. So other questions?
What happens if you treat an NMOSD patient with an MS medication?
Good question. Probably depends on what MS medication. The slide I showed of our little handout that we give to patients, I highlighted the B-cell treatments. And because B-cell treatments work on antibodies, and because rituximab is a B-cell treatment that is essentially identical, it's made by a different type of tissue culture, but rituximab does have an impact on NMOSD. So I think by inference, we can say that ocrelizumab, the identical molecule, and perhaps the other B-cell therapies that work in the same way as Rituxan and ocrelizumab might also have an impact on preventing antibodies. And as I showed, there is one aspect of how the nerve cells are damaged that is antibody mediated. So lowering those antibody levels, even if complement and antibodies are combining to cause the problem, lowering those antibody levels will lessen the problem. As I mentioned earlier, though, there seems to be a real difference between complement drugs and antibody drugs, certainly in the speed of onset. And early on, cross-trial comparisons, we have to say they look like they might be a little more efficacious too on the complement side, although you get trade-off of issues of meningitis and things like that.
But would any of the medications be dangerous to give to an NMOSD patient?
So the danger in giving an MS treatment to an NMO patient is not that the MS treatment is going to cause them harm. It is the disease itself. If you do not have that patient with NMOSD adequately protected, just back to that one and done. One relapse, they may never walk again. One relapse, they may never see again. I think eventually the hiccup stops if they get area postrema syndrome. There's a lot of other things that happen. So the real risk is not the treatment risk. It's the opportunity cost. It's lost opportunity to intervene and prevent something from happening to the individual with NMO.
Thank you. Now we'll go back to MS. A little bit of NMO, a little bit of rock and roll MS. Yep. Okay. Let's talk about MS relapse. For those that are new in the scene, whether they're online or in-house, what do you have? What is available, and how are people being treated for MS relapse?
That's still your father's Oldsmobile, I'm afraid.
There are new people.
Yeah, we really haven't made
describe to the new people
of all the progress. I can point to all the progress in that early slide I showed you with this exponential ramp up in treating NMOSD treatments for, but we haven't had anything like that for MS, at least MS relapses. So it's still the same old thing we've always done. First line is steroids. So we use usually for a major relapse, we still tend to use intravenous Solumedrol. Quite frankly, when I first started treating, the very first relapse I ever treated in my residency as I was chief resident, that was a long time ago, we used ACTH. We did not use steroids. At the time, Solumedrol was not the standard of care. So adrenocorticotropic hormone is like a hormone that causes your body to sort of pump out a whole bunch of naturally occurring steroids. Does a lot of other things beyond that too. Steroids, ACTH, those are old things. Probably something somewhat more recent, IVIG to treat relapses. It's like immune globulin that's purified from the nation's blood supply, and we give that back to you in really high doses, almost like it kind of resets the immune system. And then a condition called plasmapheresis. Plasmapheresis is a procedure. It's more similar to dialysis in that it's a filtration procedure where your blood is filtered. With dialysis, toxins that your kidneys can't clear is what the filters are set to filter out. With plasmapheresis, we set the filters to remove small proteins that the immune system is using to communicate. And that can have a pretty pretty big impact. Plasmapheresis, because it requires a central line, you got to have a central line placed either in your neck or in your chest or something like that. That's uncomfortable, and you can't shower the whole time you have that on. The procedures take a lot of time. People are really fatigued afterwards. Reasonably safe, but it's just much more of a hassle. So we tend to use pheresis in someone who has a really large, significant neurological deficit. If they had a really bad brainstem syndrome with balance problems or major spinal cord event. There actually was if someone has profound vision loss, like some of those visual fields and optic nerves I showed you there, that would be a candidate for plasmapheresis. And by the way, I'll mention that for attacks of NMO and NMOSD, plasmapheresis is the way to go. We don't treat an attack of NMOSD the same way. Steroids and actually some of our MS drugs have been postulated, the interferon drugs have been postulated to maybe worsen NMOSD. So I'll tack that on as a caveat to the earlier question that has been postulated, and a couple of studies have suggested that some of the MS drugs might actually worsen NMOSD, but they definitely won't help it. They won't worsen it as much as the impact of a single NMO event. So I still think that's the biggest risk is opportunity cost. But we don't treat relapses of MOGAD, NMOSD the same way we treat relapses of MS. Quite different things.
Okay, thank you. So a person online writes, is Acthar, because he didn't mention it by name, the same as ACTH?
Acthar is one brand of adrenocorticotropic hormone, ACTH. Yes.
Thank you very much. Okay, and then the other question was regarding the NMOSD drugs. I wasn't in the room. How many were mentioned by you?
4 on label by the FDA.
Right. Okay. I thought the 4th was approved already.
Yes.
Okay, great.
All
All right.
4.
Anybody have questions? We're out online. Don't see any hands up. I'm going to save the doctor his voice.
Anybody online know what the score is in the Stanley Cup final?
Oh my gosh.
Stewart, by the way, scheduled this on Game 7 when his Florida Panthers are playing my Edmonton Oilers, and he scheduled this on the very night. I'm sure you knew that was going to happen.
You
Stuart.
do know that this was scheduled like 4 months ago, right?
Yes, but aren't you?
And we did not know the Oilers were going to get lucky enough to even get in.
I knew. I believe.
Let's call it a night. Say goodnight. I want to thank Alexion for sponsoring tonight's event and all of our exhibitors. Thank you again for being here. And Dr. Calkwood, thank you for getting out here to be able to speak despite the problem with your voice box.
Pleasure.
Thank you.
Thank you, Stuart.
Goodbye.